Peace and blessings, everyone. Welcome to a special edition of Spotlight. I'm Eduenka, and I'm here with Dr. Michael Kachmar. He is a podiatrist, and he's with the Health Services Authority here in the British Virgin Islands. And we're going to have a great discussion, very informative discussion about ailments and diseases of the legs and the feet. And we are going to talk about what you need to pay attention to, what symptoms you need to look out for, how you need to prevent, and how you need to treat various ailments and diseases that might affect your lower extremities, mostly below your knee, from your knee down to your feet. So we're going to have a really important conversation. So don't miss it. Don't go away. We'll be right back after these words from our sponsors.
This program is sponsored by the law firm of J.S. Archibald & Co. and by the trust company J.S. Archibald Trust Services Limited, both of Roadtown, Tortola, BVI.
Welcome back to Spotlight. I'm here with Dr. Kachmar of the Health Service Authority. Dr. Kachmar, welcome to Spotlight. It's good to have you.
Thank you. Thank you. Glad to be here. It's an honor and a privilege, and I'm very happy.
Great. You've been here for a while now as a podiatrist.
Yes. Several years.
Yeah, up to 2 or 3 years?
Yes. Yes.
Yeah. And this is the first time we're getting an opportunity to have a conversation.
Well, I've been very busy.
Yes. You find that we have a lot of persons in the BVI with lower extremity ailments, like leg and foot injuries and diseases?
Yes. In fact, that's one of the reasons why I was contracted to come here. One of the main issues that I deal with is venous disease, which develops into these ulcers on the lower extremity. Very common in the Caribbean. And that's one of my specialties.
Okay. Now, when people hear the word podiatrist, for those who might have an idea, they usually think of a foot doctor. And usually it has to do mostly with your feet. But so tell us, in the broader sense, what a podiatrist actually is and does. Right.
Well, there's different levels of expertise in the whole world. In the United States, podiatry is regulated by each state. So each state has a set of scope of practice laws and regulations. I'm from New Jersey, and my training, I am a board certified in reconstructive foot and ankle surgery. And also I'm a board certified in the American College of Foot and Ankle Orthopedics and Primary Medicine. So I have an extensive training background. Not every podiatrist has that level of training. So it depends on what state you practice in and what level of training you have attained dictates what level of scope. So I've had a very extensive training, and so my scope of practice is very extensive. In the States, I do trauma surgery of the foot, ankle, lower leg, infections, tumors, reconstructive surgery, especially on children. So that's my expertise. So, but there are other podiatrists in other parts of the United States and in the world that may not have as much training as I do. And there's also people in the United States who are in big institutions, universities, and see more even concentrated, extensive pathology. So to answer your question simply, we are bound by a regional restraints. So I take care of almost anything in the lower leg.
Okay, and that's from where to where? What part of the body?
Well, it depends. If a good example with the veins. If I see somebody come in with an ulcer on their ankle, that is caused by disease of the vein all the way up to the groin. So I will treat that vein all the way up to the groin to take care of the ulcer on the foot. If somebody comes in with a rheumatological disorder, I'm going to give them medication that goes all through the body, but affect a cure in the lower extremity. So, and I do definitely work with specialty referrals if I feel it's something out of my scope. So, but most of my surgical surgery is focused on the foot and ankle and lower leg. Ankle, foot, reconstructive surgery, but we'll take skin grafts from the thigh, things of that nature.
So it's mostly below the knee?
Yes, for the most part. Most of my surgery is below the knee, yes.
Okay. Now, what types of diseases that we have that's below the knee?
Well, the biggest thing, as I said, is the vein disease, the venous disease that develops into ulceration. And these are very debilitating diseases. You'll have an open sore on your ankle or your lower leg, and they drain, and they're constantly in need of care. Most of these people that I see are going to the clinics that do an excellent job treating these wounds 2-3 times a week, and they've been going there for months, if not years. And so that's something that I really focus on. And with the new technology that we have today and the procedures that we do, it's easy to take care of these patients. It's very low risk, and a lot of them, over 80%, 90% are cured. We eradicate the disease process. So that's a big focus of my being here.
And what caused that type of disease?
It's a good question.
And that disease, the vein disease, is prevalent here?
Yeah, I'd say the extensive vein disease is very prevalent here. In the States, vein disease is probably about 25% of the population. And if in the United States, in the population I look at, about 10% of the group of, if you take 100 patients with vein disease, aggressive vein disease or advanced vein disease, about 10% will have ulcers. Here, it's almost the opposite. It's almost 90%. And there's a large amount of ulcer disease related to the vein disease. I don't know why, but I see that.
Okay, so, before you answer what the causes of the vein disease, I want to get a more graphic picture of what that actually is. What happens when a person has vein disease and what it looks like?
Well, what happens is, and I'll give you a little bit of an anatomy lesson. Your heart pumps blood from your heart down to your extremity through arteries. And I always tell people, think about A-away arteries. And the blood has to come back. And the blood comes back mostly through the veins. There's another system called lymphatic system, but we won't get into that. But vast majority of blood comes back through the veins. Now, the blood going down the arteries is pumped by the heart, so it's a pressure that pushes it down. The blood gets back to the heart by way of muscle contractions. The muscles, when you walk, squeeze the blood through the vein, and the blood goes up the vein. Now, when you stop walking, the blood wants to go back down, but it usually doesn't because there's one-way valves. Now, if those valves are damaged, you'll get what's called reflux. The blood will go back down. It creates pressure in the lower extremity. The leg starts to swell. You start to get discoloration. And because of the blood stagnating there, it creates an unhealthy environment where you start to get minor skin infections. If a little scratch won't heal, and before you know it, it gets bigger and bigger. The skin changes, more discoloration, and then you get a break in the skin, and now you have a festering wound we call an ulcer. So it's the backing up of blood, and we call that venous hypertension or venous reflux, and that's the disease process.
So if I could make it clearer for me, that blood is unable to, I guess, reoxygenate because it's not going back around the heart, and so it doesn't have the qualities any longer to ward off infections and diseases.
And what happens is the veins, because of that load of fluid, the veins start to get bigger, and then fluid starts to come out of the veins into the interstitial tissue, and you get swelling. So it creates a whole unhealthy environment. There's some other things that are going on with the immune system because of this local hypertension, but for the most part, you're absolutely right. The blood is not healthy, and it's stagnating there, and that's not normal.
Okay. And what causes that now?
Well, there's, I could throw the old heredity. Definitely genetics has a lot to do with it. We know things aggravate it: pregnancy, prolonged standing. But getting down to the basics, from a histological standpoint, the disease valves seem to be a big part of it. We don't really know. I don't think anybody really is a true answer. We know it's genetic, but we can't put a finger on one thing that causes it.
But if it seems, based on what you're saying, that if the muscles need to contract in order to send the blood back to the heart, then exercise is a major factor.
Well, it helps. I mean, no doubt about it. Walking helps to bring the blood back. Compressive dressings help. but we don't know why the fundamental disease process starts, why the valves don't work, why the blood is not going back up effectively. Because people have good muscle strength. It's something to do with the vein wall and the vein valves. Okay. And there's a lot of research right now, a lot of people are looking into this, trying to figure out why it is happening. Until they do, we're treating it. We're trying to treat it the best we can.
Okay. Do you think that nutrition may be a factor in the breakdown of the valve system? It's not getting what it needs to function properly nutritionally?
Well, we see it worse in people who have poor nutrition, but there's a lot of people who don't have poor nutrition and have the vein disease. We used to think that, I've seen women after pregnancies it's aggravated, but we have a lot of men who have vein disease. So again, we just don't know. I wish I could give you an answer to that.
So, but you treat that. Then how do you treat that?
Well, initially we need to diagnose it, and when we have a patient come into our office, usually they have some symptoms. They either have visual veins that they see, they're painful, or they have some discoloration. Sometimes the first thing we see is in the ankle area, mostly the inside ankle, they start to get skin changes, color, discoloration, darkening of the skin. And they're very concerned about that. They may be referred by their primary doctor or another physician who might be, say an orthopedic surgeon might be thinking about doing some surgery on their leg and are concerned about this, there might be a vein disease. But anyway, they come to our office and we make the diagnosis. How we make the diagnosis is by history, and then we do what's called a vein mapping. We take an ultrasound machine and we look at the veins. We could show reflux. We could visually see it by certain maneuvers. And once we find that there is reflux in the vein, there's several, and we look at the level of disease. So once we have the disease diagnosed and quantified and qualified, then we could treat it. And the treatments that we do, to answer your question, we burn the vein. We actually put a laser catheter or a radio frequency catheter into the vein, and when we put the laser on, or the RF, it heats the vein up, and it actually closes the vein. It coagulates it. So we pull the laser, as we pull the laser out, it closes that vein, and the vein does not reflux anymore. And you don't need that one vein, it's diseased anyway. The other thing we do is we actually inject medicine, a sclerosing agent that actually irritates the vein wall and closes it down. And we usually do that with ultrasound. We can see the vein and we put the medicine in. And then the third thing we do is we actually pull little pieces of vein out. It's called ambulatory phlebectomies. It sounds painful, but it's not. And we'll actually take some of the superficial veins out. So we do those three things. We do what's called venous ablation. We kill the interior of the vein wall one way or the other, either with laser or radio frequency. We inject them, or we actually pull little pieces out. So that are the treatment regimes.
So those are veins, the veins that you close down, you take them out, they no longer function?
Right.
And you don't need those veins to send the blood back up?
Well,
so what happens then?
Yeah, well, your vein system, you have three components to your vein system, to answer this question. You have your deep system, your superficial system, and perforators that communicate between the two. All the disease, most of the disease, is in the superficial system. And the superficial system handles about, or carries about 10% of the blood supply. So it's not a lot. And in fact, the vein that we're destroying is the same vein that historically has been removed to do bypass surgery in the heart. They'll actually take that vein. So, and again, the vein is not normal and it's not functioning well. So
it doesn't have that impact.
No, and then the other veins, the other systems pick up the flow again.
Now, how is early detection any help?
Absolutely.
Okay.
Absolutely. I found now that, especially down here, because the disease it progresses into ulcer formation, it's so much easier to cure it in the early stages. There's less disease, there's less collateral damage. And what I'm starting to find out is that once you get these ulcers that have been there a very long time, there's so much damage to the tissue that even if we correct the vein disease, the reflux, it's still sometimes difficult to close that wound. We have to skin graft it. because it's been there for such a long time. There's been so much damage. So just like anything in medicine, the earlier the better.
Okay, we got to take a break for a word from our sponsors, and when we come back, we're going to talk about what we can do to identify that something is happening to your veins, as well as we're going to talk about other ailments and diseases of the lower extremities. Keep it locked right here to Spotlight. I'll be right back with more of Dr. Latchman right after this.
Spotlight is brought to you by CCT Global Communication, DataPro, Orion Law, Clarence Thomas Limited, Virgin Island Motors, and Bolo's Wholesale Cash and Carry.
Welcome back to Spotlight. I'm Ed Juenka, and I'm having a great conversation with Dr. Michael Latchmar of the Health Service Authority. He's a podiatrist, and he's here with the Health Service Authority to deal with all of the ailments and diseases of the lower extremities, like from the knees down. And we're having a great conversation. We left off talking about veins and vein diseases and treatments. And I want to continue the conversation, Dr. Latchmar, with what can we do, since early detection is helpful. What can we do to detect our challenges with the veins early?
Well, when people come in my office, some of the earliest signs is what they tell, and what I see is their veins start to become prominent. They see them maybe when they're taking a shower or when they have.
So they're bulging.
They start to bulge, or they become prominent, or they can see them. They're visually becoming more visual. Some people, the first signs of vein disease is they get discoloration around the ankles. They'll just see the ankles will start to get darker, or they may swell, and that's some of the early signs. And some people will have burning, some people have itchiness, some people will have symptoms where we call it restless leg syndrome, where when they sleep at night their legs feel uncomfortable. That's some symptoms. Also, by the end of the day, some people will start to have swelling. They'll wake up in the morning, their legs will be normal size. By the end of the day, there's quite a bit of swelling in the legs. And then by the next morning, it goes away. So those are some of the early signs: swelling, burning, tingling, itchiness, discoloration, prominent veins. Some people will actually, they'll have veins that start to get so big they'll bleed. I'll have people come referred to me from the emergency room. They'll have these large veins. Never really had any problems with them. They figured they're no big deal, and then one would burst open and bleed. And so they would go to the emergency room, then be referred to us. Hopefully we'll see it before, get it before that level.
Okay. So is this something that a person should be checking themselves on a regular basis, or at what point in your life do you start looking for this sort of development? It's like, you want to get a mammogram early, you test yourself as a female for lumps and so on. Do you have a similar situation with this development?
It's a great question, and vein disease can start in a very early age. I've had patients here that had aggressive ulcer disease in their 30s. I can think of 4 patients right off the top of my head right now. Having said that, I don't think everybody needs to have a vein testing done, but if you're just like any other disease process, if you're at high risk, then I would say it might not be a bad idea to have somebody evaluate it. So who's at high risk? Well, definitely if your parents have vein disease, or your brother or sister, so family. No doubt about it, family history is very significant. And that's true for heart disease and any other medical problem. So I think if you have had a family history, if you've had a phlebitis, which is a blood clot, again, you may not have any idea that you have vein disease, but you may get this what's called phlebitis, especially superficial phlebitis, which is an inflammation of vein. If you have that diagnosis, we definitely want to see you. And so I think that's it. And if you have any prominence veins that you're concerned about, or some swelling that you're not aware of, but you don't know why it's being caused. So from a prophylactic standpoint, I think the biggest thing I can say is family history. And then after that, if you saw any signs or symptoms.
Okay. What are the other diseases or ailments that you treat, you recognize while you're in the BVI as a podiatrist?
Well, my other hat that I wear is my orthopedic hat. I'm a specialist of the lower extremity orthopedics. I see So I'll see an array of ailments. A lot of people will come in with arthritis of their foot, ankle. We call it degenerative arthritis, and their knee. That's a very, very common problem in the United States, as well here, or worldwide. And so I'll see that, and it causes a lot of pain. People have difficulty ambulating. That's usually what brings them to me. They're limping, they can't walk, and they're concerned. They'll have pain in their legs. I'll see a lot of people come in my office. They don't know what their problem is. They'll have generalized pain. We rule out vascular. We make sure there's no arterial disease, venous disease, and then we start looking at the orthopedic aspect: muscle, tendons, bones. And a lot of people that I see here have arthritis, just like in the States. And for that, we have a lot of very effective treatments. We use a lot of cortisone injections, which give people a lot of relief. So that's what I haven't seen here a lot.
Okay. And of course, arthritis is, describe what arthritis is for those of us who don't know, especially, I think, is that a disease that mostly afflicts older persons?
No. I wish it, no. Well, first of all, there's many arthritises. There's probably about 110 different types of arthritic ailments. There's rheumatoid, there's lupus, there's inflammatory arthritis. The list goes on and on and on and on. The most common that I deal with is wear and tear, degenerative arthritis. And what arthritis is actually, when you look at a joint, you have two bones, and when the two bones come together, it forms a joint, and that joint moves. And what interfaces between the two bones is cartilage. When you take an x-ray, if anybody's seen an x-ray, when you look at a joint, you'll see a clear space. Well, there's no clear space there. That's actually cartilage that is radiolucent. And what happens is that cartilage, in arthritis, the cartilage starts to degenerate. It starts to break down and get thinner, and you start to get to the point where, in advanced cases, you have bone on bone. So that's arthritis. So it's a degenerative process of the cartilage, most time. And there's other arthritis that cause inflammation, but again, that's what's happening. And it causes pain.
Okay. So when the rubber that's between the joints wears off, like the iron start clanking together.
Yep. Yeah.
I don't know if that's a good analogy.
No, it's not a bad.
It just came to my mind from a vehicular perspective. That you have that's a similar thing.
Yeah, and what happens is you get decreased range of motion. You have pain. There's swelling, and you can't do your daily activities.
Can those cartilages be replaced once they're gone? That's it.
No, there's my treatment right now is palliative. I'm trying to help the people feel better and get them moving. Advanced cases, you need to bring in surgical intervention. In the lower extremity, we use implants. We'll actually fuse joints. For knee, for example, in my area, they do total knee replacements every day. In the lower extremity, foot and ankle, we'll use metal or plastic implants. We'll actually fuse joints. Some of the joints will actually, because it's so arthritic, we'll put them together and actually put a screw or a plate across it, and so there's no more movement and no more pain. So there are a lot of surgical interventions that can be done.
Okay. And do you do that here? What of those treatments are you able to do here?
As of now, I have not started doing any surgical intervention. And I've been so busy with the veins that was my main focus. Hopefully in the near future we're going to start doing that. The problem with the orthopedic treatments is that we need a lot of follow-up. So I need to be here longer, and we need to have other physicians that are going to follow up the patients. The veins lend itself to very quick and easy procedures that have a small amount of rehab. The orthopedic becomes more intense and longer. Right now, I refer to the local orthopedic surgeons who are very good for care that I can't render.
Okay. What are some of the other diseases that you find here? And before I get to basically most of the diseases that can be developed, so I'm looking at what you've been finding here while you're here, so we could get a sense of the data of what's happening with the local population.
Well, again, just like at home, we see a lot of heel pain. Something that's really common here, and people, it's called plantar fasciitis, heel spur syndrome. And the symptoms are people get up in the morning, the first couple steps, they have a very difficult time walking, have severe pain in their heel. And it eases up. By the end of the day, it's hurting again. And going from a sitting to a standing position, they have a lot of pain. So we call it heel spur. Very, very common. I was seeing patients this morning. I probably saw about 4 patients with this ailment. And it's very debilitating. It's pretty easy to take care of. We usually give cortisone injections. We try to get the patients into a different shoe environment for a short amount of time, preferably a running shoe with a nice orthotic, some kind of insert, and some physical therapy. And that usually, over time, takes care of the problem. And about 95% of people cured without surgical intervention. So that's very, very common here.
Okay. And these things sneak up on you without any warning. I suspect the heel pain particularly.
Yeah.
And you have the medical profession been able to figure out what these things are caused from?
Yeah, again, you know, wear and tear, walking. I don't think that our feet were really made to walk on macadam and concrete and go in these flat shoes. So I think it's part of our society, the way we're walking. It's an overuse injury, just like lower back pain. So,
well, that's interesting. So you're saying that a lot of the shoes that we wear and the ground, the concrete, the asphalt that we walk on is not good for our feet, is not good for our bodies? Is that what they're saying?
I go, you know, I'm a naturalist. I mean, if you again, you know, you have to. I'm a doctor. I'm a scientist, you know, and I look at the human body from that aspect. And I think that if you really look at the foot, we're made to walk on uneven terrain, even without shoes. That's probably the best environment. It keeps the muscles strong. You know, we're used to going over branches, trees, walking on sand. You know, now we have this environment where it's flat. We put the foot in these shoes, especially women. They try to put a foot in a shoe that's way too small, and these aggravate a lot of problems, or cause a lot of problems. There's a lot of studies that show that high heel shoes are really bad. They cause a lot of problems, especially bunions. But no, I think that aggravates the situation. It's an overuse injury, and I think if people, you know, exercise and walked without shoes, they'd probably be better off. But you can't do that on concrete or asphalt.
So the exercising motion that the feet goes through over a terrain where it's more undulation, more climbing over, and having the foot move in different forms and shapes, that exercises the foot and keeps whatever needs to be kept in good condition that way.
Yeah,
that's interesting. Something totally new. Well, okay, so we have all the concrete, we have all the flat surfaces. What kind of shoe we would need then? Are those types of shoes being made that are better for your feet?
Yeah, I think the best the best shoe environment, in my opinion, is a nice running shoe, even though you're not going to run. You got to remember a couple things about a human being when they walk. When you walk, you hit the ground with your heel twice your body weight, and then when you push off, twice your body weight. So let's just say you weigh 200 pounds. That's 400 pounds coming down every time your heel hits the ground. You walk a mile, you're hitting the ground over 1,000 times. So you need something that's going to absorb shock, number one. So a good cushiony shoe, and that's a running shoe. Also, you'd like to have something with some arch support, and that's a running shoe. Also, the running shoe, they usually breathe. They have kind of like
porous material.
And so it breathes. So a running shoe is some of the best environment you could be in. Of course, a lot of people don't like to wear a running shoe because it doesn't look nice, or they think it doesn't look nice.
Not dressy enough.
Yeah, but that's a great shoe environment, yes. And in fact, I'll have people with plantar fasciitis. Here's where I say that. I'll have people with plantar fasciitis come in. They have really bad pain.
With what?
The heel pain, the heel spur.
Oh, heel pain. Okay, good.
And I'll put them in a running shoe, and they improve. Without sometimes not doing anything else.
No medication. No.
Sometimes they can't. They don't want an injection. You know, I always push the injection. They don't want to take any medication. So I say, okay, let's try get you into a better shoe environment, and much improvement, definitely improvement. So it makes a big difference. Big difference.
You mentioned women's feet and bunions. You see a lot of that here as well.
Oh yeah.
Mostly females, male as well.
Yeah, bunions are 80% women. There's a lot of studies in the States that prove pretty well that high heel shoes accelerate bunion deformities. And what a bunion is if you had your foot, it's the big toe. The big toe drifts over towards the second toe, and the metatarsal, which is the bone here, starts to go out. So you get a prominence, and it can be very painful. No doubt about it, the high heel shoes aggravate it, and we see quite a bit of that here. And in the States, what I do in my office, in my practice, is we'll try conservative therapy. We'll try to get them in a wider shoe, try to lower the heel. One of the things that we recommend is if you're going to wear a heel, try to make the heel height no more than 1.5 inches. That seems to be a cutoff number where you have less symptoms if you keep the heel low. I prefer no heels, but anyway. And then we'll try injections, anti-inflammatories. And if people continue to have pain and disability, we actually operate on them and we correct the bunion.
But you need, along with having a flatter shoe, you need a wider shoe.
Yes.
You need a shoe width as well.
Yes. Yeah.
Okay.
Yes.
Now, there's something on the top of the toes that we call them here con.
Yes. Yes.
Okay.
Yes.
Does that have a relationship to bunions,
Yes.
or that's a separate thing altogether?
Well, it's hammer toes. What's happening is the toes start to, I believe what you're talking about is that the toes start to hammer. They start to go in this direction. And there's a lot of reasons for it. One of the primary reasons is that there's an imbalance between the tendon on the bottom of the toe and the top. And my finger goes up and down because there's a tendon here and a tendon here. And those two tendons are in balance. That's what makes my finger go up and down. Same thing with the toe. Well, if the tendon on the bottom gets a mechanical advantage of the tendon on top, it'll go like that. And then you're walking, the shoe rubs here, and you get what we call a callus.
Yes.
And that becomes a problem. And so it's an imbalance between the tendons. One of the main causes is a bunion. What happens is when you get a bunion, it sets up a dynamic imbalance between these metatarsals. It's a complicated scenario, but suffice to say that causes this. But there are other reasons for it, and genetics plays a big part. But you do see it. There are ways to fix that. Of course, wider shoes, a bigger toe box. But eventually, if it gets where the toes don't move anymore, they get rigid, we actually operate and take that joint out and fuse them straight. You can still move this joint and this joint, but now you don't have that deformity.
That flexibility.
Yeah.
And you get mostly it's just a few of them at a time. Is it normal that you get them all across?
Yeah, you could. Sometimes just one or two. Sometimes it's the second one. It's very prominent. Or the last two are very common. Depends on the etiology. And there's some sophisticated. It would take me an hour to tell you to figure out. But there are mechanical things that are happening. Excessive pronation, flat foot. There's high arch foot. All of these different kind of genetic predispositions.
Shoes play a role in creating that as well?
Yes.
Okay. We're going to take another break, and we're going to come right back with more Dr. Latchmar on Spotlight right after this. Don't go away.
This program is sponsored by the law firm of J.S. Archibald & Co. and by the trust company J.S. Archibald Trust Services Limited, both of Roadtown, Tortola, BVI.
Welcome back to Spotlight, and the first thing I have to do is I have to correct my pronunciation of Dr. Kachmar's name. It's Dr. Kachmar and not Latchmar. So that's my mistake, and I have to apologize for that. It's Dr. Michael Kachmar, and he's here with us. He's out of New Jersey, and he's here with the Health Services Authority as a podiatrist. We not commonly call a podiatrist foot doctor, but of course we're learning today that there's a lot more to podiatry than just just treating bunions and toe blisters and so on, right? So we're having a good discussion, and I hope that you're getting a lot of information. Okay, we left off talking about bunions, and then you have injuries.
Yes.
Yeah, a lot of us have sports injuries and just regular injuries. Talk to us about some of the injuries that develop in that area and how that's caused and how it's treated.
Well, just a few days ago, I've had several patients who have come in with ankle sprains. That's another very common thing that I see. Most of the patients, they'll either come in as an acute injury, they happened a day or two. They'll be seen in my office, they'll be seen in the emergency room and referred to us. They either have an ankle fracture or an ankle sprain. Here I've seen ankle sprains, and a lot of times what will happen is I'll get them 2-3 weeks after the sprain, and they're not getting better. The patients are concerned. They might have been exercising, doing their exercise class or walking, and they twisted their ankle. And again, it's swelling and pain. So we'll see them on a consultation. And many times, what's happening is it just hasn't healed yet. I'll reassure the patient that they need more time. We'll send them up for physical therapy, which is very, very helpful. It re-educates the muscles and helps reduce the swelling. And we'll usually put them in a brace. They need some bracing for a short amount of time, and they usually come around. Most ankle sprains you'll be no worse for the wear after a certain amount of time. So we definitely see a lot of ankle sprains.
And we don't basically go to the doctor because a lot of times we don't recognize it as an ankle sprain. We'll know that we twist the ankle and you'll have a low pain, but you're figuring that in a few hours or perhaps a day or two, it'll go away. Mm-hmm. Is there a danger in waiting to go and see a doctor with an ankle sprain?
No, if you have a fracture, if you had a fractured ankle, usually if you had a fractured ankle, that would be dangerous.
Would you be able to tell? Would the layperson be able to tell the difference?
Over almost 30 years of practice, very rarely can anybody walk on an ankle fracture. Okay. So if you could walk on it, you're doing pretty well. I doubt very much you have a fracture. But nothing is written in stone. But for that matter, no. But usually what most people do, and I would recommend this: if you have an ankle fracture, you follow we call it RICE: rest, elevation, compression, and ice. Mm-hmm. Put some kind of compression on it. Elevate it, stay off of it, take some anti-inflammatories if you want. Again, put a nice compressor wrap. If it doesn't come around in a week or so, then I think it's time for a consultation because it's more extensive and you might need more extensive treatment. So I would say you could wait a little bit, but not too long, especially with an ankle sprain.
Okay, but they usually take care of themselves. What is neuromus? It's say it
again.
Numerous. Neuromas?
Oh, neuromas.
Neuromas. Yeah, what is that?
The neuroma, in your foot, and your hand, but in your foot, you have nerves, and they're in the ball of your foot. Everybody has them. They're normal nerves, and because of the walking and the pressure, these nerves that are in your foot have a tendency or are susceptible to injury, and they get swollen and painful. So we call that a neuroma.
Okay.
And the most common one is in the third interspace, which would be between your third and fourth toe in your foot, and it's called a Morton's neuroma. The doctor who first recognized it wrote a paper on it. His name was Dr. Morton, and they they call it a painful Morton's neuroma. And you'll get the symptoms. You'll get pain. While ambulating, a lot of times people they'll take their shoe off and they rub their foot and they feel a lot better. Mm-hmm. They may get numbness and tingling in the toes, but it's a dull ache in the ball of the foot, and it's a swollen nerve, and that's what as a neuroma.
And is this something that we can put up with until it heals itself, or something that we need to come and see you about?
Well, change of shoes will help. Once that happens, again, getting into a soft environment, getting out of the heels. There are some activities that aggravate it, especially when somebody is pushing off with their toes, like pushing say a cart or an object. Try to refrain from that. If that doesn't help, and if you're taking some anti-inflammatories, then it's time to come and see a specialist. You don't want the nerve to get permanently damaged, because then the only treatment is to remove it surgically. Usually what we do is we'll take an x-ray, make sure there's nothing else that's causing the problem, and clinically make the diagnosis of a neuroma. And again, a cortisone injection calms the nerve down, and we get them out of their shoe gear, try to put them in a more accommodative shoe. And again, that usually runs its course. 95% of people cured with conservative therapy with an aroma.
Okay. Ingrown toenails. You find a lot of that here?
Yes. We see a lot in children. Ingrown, and again...
And describe that for me too first.
Right.
So
ingrown toenails, a lot of people have a misconception. In children, in young adults, an ingrown toenail is a normal nail that actually grows out and digs into the side. It gets inflamed, it might bleed, there's red tissue, it's very painful, it gets infected, it's red swollen, and that's a true ingrown toenail. It may have to do with the child or the person as they grow, maybe inappropriate shoe gear. And what we do for that is we actually need to do a surgical procedure. We actually numb the toe up and take an edge of the nail out. It'll grow back again, hopefully not ingrown again, and that usually cures it. Sometimes we have to permanently remove part of the edge of the nail. I have some children that come in that have it multiple times. In an adult, you don't see as much ingrown toenails with a normal nail. Usually in an adult, you see it secondary to a fungal nail, and that I see a lot here, and I'll elaborate on that. But a fungal nail is actually an infection of the nail tissue by an organism. It's fungus, which is, if you put a piece of bread, you have mold, green mold, that's fungus or mushroom. So it's an organism that actually grows into the nail. It makes the nail thick and discolored, usually yellowish, but thick. And then because the nail is so thick, you wear the shoes and it pushes down into the nail and the nail digs in. And so you get an ingrown toenail, but it's secondary to a fungal nail. So I see a lot of that.
And what causes that?
We're not too sure. It's caused by the infection of the organism being introduced into the nail. Why is it being introduced and why are you susceptible to it? I don't know.
Hygiene?
Yeah, I think age. You definitely see it in the older population. As you don't see it in children as much, although I am seeing in the past 5 years more children getting it. I'm not too sure. You think about it, your body, you have bacteria in your whole body, normal, everybody does, from the top of your head to the tip of your toes, and that's your what we call resident flora, and those bacteria protect you from bad bacteria. And one of the theories that I think is going on is that in your lower extremity, maybe because of as you get older, maybe the immune system changes, maybe the temperature changes, but that bacteria lets the fungus in. It doesn't guard against, and the fungus starts to get into the feet. And that's some of the most common places is in the foot. It's furthest away from the heart. It's cooler. So there are some theories with regard to that. But it seems to be more of an aging process. Some people who have immune deficiency diseases will have fungus. So again, we're not 100% sure, but it's definitely seen more in an older population. I don't want to say elderly, but older.
Not washing between your toes, dirty socks, dirty shoes, no socks with your shoes on. Are those any? Can you attribute that fungus to any of those hygienic factors?
I think that you want to keep your feet clean, no doubt about it, just from a general standpoint. But I get people come in the office who tell me from a history that they're very fastidious about their care, and they got fungus. I think some people. I tell you where.
Is it contagious?
That's what I'm going to say. I think. Again, I don't want to step on anybody's toes, but I think that there's some perception out there, maybe some evidence that it's being passed on or by these nail salons if they don't follow a very clean technique. So they should be sterilizing instruments in between each client.
Oh, okay.
So you can give it to one person to the next.
Should you be concerned if you go to the gym, in a locker, you walk around bare feet, it's moist? Is that something that?
Well, what you can pick up there, yeah, fungus and also warts. We didn't get into that, but warts is a virus, and that is very contagious. And so in a locker environment or anywhere, you should be wearing something on your feet. I recommend flip-flops if you're or water shoes. Flip-flops are the best. If somebody has a wart on their foot and they walk on the ground and then you walk over that area, you can get the wart into your skin.
You see a lot of warts here as well?
Yeah, well, generally speaking, I see a lot of warts. Warts are very common. Again, they're more in the younger population, but you could get them into the 30s and 40s and 50s. They're a virus that goes into the skin. They're only skin deep. They don't go any deeper than the skin. And what happens is the virus takes over the DNA of the skin cell and reproduces itself. And what it causes is a round lesion. Sometimes they bleed, and they can be painful, especially if they're on your hands or your bottom of your feet, because you're putting pressure. And they're difficult to get rid of sometimes.
And how do you treat those?
Initially, what we'll do is we'll scrape them and put some chemical on it, silver nitrate. We'll give the patient a prescription for an over-the-counter topical. I think most physicians will treat it with a topical acid to try to burn it. If that fails, then we remove them surgically or we laser them. But you could burn them. But most of the time, we try topical medicines first.
You say they're difficult to get rid of sometimes. Why is that?
Well, if you see the wart, there's virus about an inch around that wart. So if you just eradicate the wart, say cut it out, there's still virus around it, and it could recur. In fact, there's about a 50% recurrence rate by removing warts surgically. What happens, the problem with warts is that the body doesn't recognize it all the time, so you don't develop an autobody immune reaction to the wart. So a lot of times you remove it and you're not immune to it, and so you pick it up again. Sometimes some people will get immunity to it, which is helpful. But again, they because it's so widespread and the virus is so much level of virus in the local area, they do recur a lot.
But being that it's a virus, do you need to, if you maintain a level of immune system function, would that be a preventative mechanism?
It should, and again, there's a lot of studies out there where we don't really know why some people are plagued with virus, warts, and others are not. I do see, I know over the years I've had patients who are immunocompromised, who have leukemias or cancers, and they'll have more warts. But because you have a wart doesn't mean there's anything wrong with you either. So you have to be careful looking at that. I think that, just like I see more warts in children, so I think that you send a child to school, they get, the child's always sick, they pick up all the viruses until they get immunity to it. And I think that's what's happening with warts. I don't see that many warts in adults, older, 40s, 50s, 60s, definitely the children. So I think what happens is eventually they get immune reaction, and then they don't get them anymore.
And then we have to be careful, particularly nowadays where we are out in a lot of area where there's a lot of people with walking around bare feet and in moisture in gyms and swimming pools and other facilities, that we need to be mindful that we have something on.
Yes.
On the bottom of our feet.
Yeah. Because you'll get the two things you'll get is a fungal infection, which could not just be the nails but in the skin, and we call it athlete's foot, and it could spread to different parts of the body. You touch it on your hands and you can spread it. And then the viruses, the warts. Those are probably the two most common contagious diseases that I see from the standpoint of lower extremity infections.
Okay, Dr. Kachma, we're going to take another break, and we're going to come right back with more about podiatry and disease and ailments of your lower extremities and how those are treated. Keep it locked right at the Spotlight. We'll be right back.
Spotlight is brought to you by the National Bank of the Virgin Islands, Tortola Concrete Limited, Orion Law, Clarence Thomas Limited, Virgin Island Motors, and Bolo's Wholesale Cash and Carry.
Welcome back to Spotlight, and I'm having what is certainly an educational discussion for me with Dr. Michael Kachma, and he's here in the BVI working with the Health Service Authority. You, how often are you here?
I've been coming every month.
Okay.
And I like to have. I think it's important to have continuity of care with my patients. So, especially with the venous disease. So I like to follow up on my patients once a month. I find that is effective.
Okay. And you are in the Seacoast Bay Clinic?
Yes. We've taken. That's my main office. We've over the years have modernized it. We now have a ultrasound unit. We also have a laser in that facility. We have a beautiful table, a special surgical table. We have a nice monitor. So as time goes on, we've been adding and adding. We have a generator that was installed. So if we're doing a procedure and the electricity goes out, the procedure is not interrupted. And we're just getting Wi-Fi now down there, so we have internet access, so I could look up drugs and their side effects. So we're continually building it.
So it sounds like a real enhanced modern facility you have there in Seacoast.
Yeah.
So you're able to perform most of the treatments that you would in the States, right here in the BVI regarding the ailments of lower extremities?
Absolutely. One of the things that we're trying to put together too is have telemedicine, where when I'm not here, we'll use Skype, and we'll have a monitor there, and I could see patients, follow-up patients or new patients on a consultation. I'll be sitting in my office. There'll be a nurse at the Seacoast Bay Clinic, and we could communicate back and forth. And I think that's something, it's easy to do, it's really low cost, and it will give that continuity of care. So because of the technology that's out there, anything's possible.
Okay. Now, how serious an emergency can develop where you would need to be here?
Well,
how would that work?
Well, we anticipated, that's why I'm not doing a lot of orthopedics, but as far as the venous stuff, we have anticipated that, and we have mechanism in place for follow-up care if necessary. Every case that I do with Mr. Cleveland Reynolds. He's the ultrasound tech at the hospital. He's well trained, and over the years, him and I have developed a relationship. As far as his ability to diagnose and treat and understand the vein disease has improved tremendously. So he follows up on the patients, because all these patients need to have ultrasound evaluations. If any complications can happen, most of the time, and it's rare, is a clot, and so we monitor that, and we have mechanisms in place to take care of that.
Okay, so you can get back here at a moment's notice if something develops where you need to be
absolutely.
here?
Well, it's a 4-hour flight, and I'm here.
Okay.
But we have because of the telecommunications we could do a lot over the phone. That's why we're setting up Skype, and then I communicate with other doctors here who are here when I'm not here. There's plenty of talent here to take care of any complication that comes up.
Okay, and people should make an appointment with you?
Absolutely.
Okay, and the number to make an appointment is 852-7690, 852-7690 if you want to make an appointment with Dr. Catchman, Dr. Michael Catchman. He's a podiatrist, and he treats all diseases of the lower extremities, which is perhaps from below your knee. But anything that affects that area and also affects other areas, he can treat that as well. So if you need to go to a foot doctor, podiatrist, make sure you call 852-7690, 852-7690. Make an appointment, and you'll be sure to see Dr. Kashmar. And you say every month, so that's you're here 12 times a year. And for how long?
Anywhere between 10 days and 2 weeks.
Okay, so you're here quite a bit.
Yeah.
Okay. We were talking about something off air that I didn't understand a word of it, and I think perhaps it may be important for us to know. So can you break that down so I can understand?
Sure. Well, you were asking about what diseases, what could be spread, contagious. One of the things that I see in the States a lot is there's an entity. It's called impetigo. This is another thing that I see quite a lot. Impetigo is a staph. Impetigo, the word means an infection of the skin, and it's an infection by the organism, the bacteria called Staph aureus, Staphylococcus aureus. So it's a bacteria. It's very prevalent, and when you get an infection in your skin where it's red, swollen, pussy, it's usually staph. It's usually a staph infection. It's the most common. Now, most staph infections are treatable, especially years ago, with regular penicillin. But over the years, the staph has developed a resistance, and we call that resistance medicillin-resistant Staph aureus, or MRSA for short. And it's very prominent in the United States, and it's becoming more prominent in the world, all over. And so what will happen is we'll see these children who, especially in wrestling, where they have mats in the high schools and they're sweating, and their sweat develops is a prime area for the staph infection to breed. And another child will go on that mat and they'll get the staph infection. The problem is it's this superbug. It's called MRSA, and it's very difficult to treat. The normal antibiotics don't take care of it. You need to use a different kind of antibiotic. One is called Bactrim DS or Cipro. But point being is these infections could be very deadly. They could cause a lot of tissue damage and very quickly. So knowing the organisms, I know the doctors here are very on top of it, especially the ER docs, and they're very well educated. But it's something that is, when you brought up the point about contagious, and in the United States we're seeing more and more of it, and it's very difficult. You got to really treat these children quickly. And what they do now is they'll close down the whole gym, they'll close down a whole wrestling match, they'll decontaminate the mats. So it's something to be aware of.
Okay, we don't have wrestling here as a sport, right? But I suspect that if you're having exercises and you're sweating, you're sweating and you're laying on a mat while you exercise, then the same situation apply.
Yes.
So we then have to be mindful of hygiene, making sure that these things are clean.
Yes, and one of the things we do in the United States, and I know they're doing it here, is we in like my office at Seacows Bay Clinic, we practice universal precautions. So we treat every person who comes in as if I shouldn't say it. Every time somebody comes in the office, we clean down our tables, we put new towels, we disinfect everything, and that should be even in anywhere where there's multiple people using a facility, and especially in the schools. Whatever the mat or wherever, it should be cleaned, and just common sense, normal precautions, and that usually takes care of it.
Okay, and you also recommending, particularly in salons where you do pedicures.
Yes.
You are recommending that the persons operating those salons have a routine hygiene procedure.
Yes, there's chemicals, cold chemicals, chemicals that you could put the instruments in for a certain amount of time that'll kill most organisms. Actually, for there, and also the other places with barbers, if you're doing shaving, I mean, I'm very sure they do it, but any place where there's a potential for body fluids to be transmitted, you need to be very cautious about it and sterilize or decontaminate those instruments or use disposable instruments.
Okay. You still have, we fall on a Terminator clock. So if I forgot anything that I should have asked, perhaps you might want to say something at this particular point to bring something else to our attention.
Well, just that I'm here. I appreciate people coming and trusting me for their care. I want to let everybody know that I'm very serious about delivering high-level quality care, and I believe in treating my patients like family members. That's how I do it in the States, that's how I do it here. You come in, I'll treat you like my brother. I try to do the best I can, and I'm very interested in having people get better. So. Okay.
The number to call is 852-7690, 852-7690 to make an appointment with Dr. Michael Kachma, the podiatrist here with the Health Service Authority. How long are you here for now this time?
I'll be leaving Friday, but I've been here for almost 3 weeks this time.
So you'll be leaving Friday. Is it too late for somebody to get in to see you before?
No, we have hours tomorrow and Thursday. Probably Thursday would be a good day to see some people.
So tomorrow is Wednesday and Thursday, and Friday you're gone?
Yes.
Okay, so there's still an opportunity if you see something on your, developing on your feet, some pain in your heel, some veins that's bulging and red and bleeding and discolored. It's a good time to call.
Oh yeah, absolutely.
Yes, and the number of course is 852-7690, 852-7690. Dr. Kachma, has been a real pleasure.
Thank you very much.
Thank you very much for coming to Spotlight.
Thank you.
Yes, well, this has been a special edition of Spotlight. Spotlight is going to be seen on Sundays. We have a change in our Sunday showing. It's Sunday afternoons at 2:30, no longer at 4:30. It's now, you can see Spotlight on JTV channel 55 at 2:30 on Sunday afternoon. So make sure you don't miss Spotlight. Thank you very much for your words of encouragement, your suggestions and criticism. Continue to email me at jtvspotlight@yahoo.com. I'm Ed Juenko, reminding you that when the spotlight is on, you see the facts. Peace and blessings.
This program is sponsored by the law firm of J.S. Archibald & Co. and by the trust company J.S. Archibald Trust Services Limited, both of Roadtown, Tortola, BVI.